Thank you for coming to the TA call today, everyone. We're excited that you're here. With us today is Dr. Stacy Hunt. She is a psychologist and she's a clinical director at South Central Human Service Center. She's been there for 14 years. Today, she's going to be sharing with us information on common mental illness diagnoses that we might see, including like anxiety and depression. And if you have questions, feel free to put them in the chat or raise your hand and she'll get them answered for you. So thanks for coming, Dr. Hunt.
Yeah, thank you. So Monica had asked me if I would do a basic training on recognizing understanding different mental health diagnoses that are very common with the clients that we serve with 1915I, and then maybe just talking about understanding some of the symptoms, and then how do you work with those clients. So feel free to ask questions, feel free. Sometimes as psychologists, we have a kind of a harder time explaining things in a way everyone understands. So if I say something and that sounds confusing to you, I can just let me know. Okay, I'm gonna share my screen. Now, forgive me, this is the thing I don't do as well. I have Teams down at this point, but sharing my screen isn't the easiest. Okay, can everyone see this?
Yep, it's showing up for me.
Got it. Okay. All right, so let's talk about different, even though 1915I has an extensive list of diagnoses that qualify, including all of our substance use diagnoses. It's almost all the diagnoses in the DSM. I personally helped to create the list, so I know which ones are on there. Pulled them all out of the DSM and sent them to Monica. But there's working here at the Human Service Center, we work with the same kind of folks that you guys serve, the same folks with the HUDA score and a diagnosis that would qualify them for home community-based services are also the core population of the HSC. So I have a fair background and knowledge on working with different serious mental health diagnoses is what we call them. So there's a category called SMI, or serious mental illness. But before we start talking about diagnoses, let's talk about a couple of the mental health myths versus facts. So even though we have different diagnoses and diagnostic categories, no two people with schizophrenia respond really the same. So you can know their individual kind of diagnosis and, oh, this person has a psychotic disorder, but their symptoms are and how they respond to that are very much personalized by person. Mental health systems, I would say sometimes can be cured, like we say, but most of all occur on a continuum or spectrum throughout the entire lifespan. So there's definitely people who, maybe they have a bout of depression, like after they lose a loved one or something happens to them in their life that's troubling and they feel depressed, and then they work through it, maybe in counseling with using some coping skills. Maybe they try some medication and they're not depressed again. Like that was just a one-time thing. But it's really common for our diagnoses that we see, like anxiety, depression, post-traumatic stress disorder, to be more like relapsing remittent, where there might be periods of times where you have a lot of those symptoms, a lot of anxiety symptoms, and then you feel okay for a while and then it comes back. And so it's important to really like pay attention to your own mental health and recognize, just as we do with substance use disorder, that recovery is a really, like, we work on a chronic disease management model, meaning that we think of mental health and substance use disorders as, disorders mainly of the brain and of the neurological system that can come and go and that relapses are a part of the disease. Okay. Most people respond positively to individualized recovery-focused mental health treatment. And so even our folks who are really like they're coming to the HSCs really substantially impacted by like a psychotic disorder or really deep depression, most people can learn skills, coping skills in their life to recover, respond positively. Um, and we need to figure out what the person's motivation is in order that they want to be successful. So this is, always asking like, what do you want what do you want your goal to be? Like, why are you here? Sometimes people come to us because they don't want to be there, or someone makes them, or like a third party makes them, like a court or PO, social services, and they're just kind of going through the motions. But if you find their motivation, that is really helpful, and it helps you tailor your treatment to the person better. Okay, so common mental health diagnoses that you would see, there's several different, so I'm just going to explain like kind of broadly anxiety disorders, but there's many different anxiety disorders. There's panic disorder, panic attacks, agoraphobia, which is the fear of being in large spaces, and then there's like obsessive compulsive disorder, which is a type of anxiety disorder. But in general, anxiety disorders are a group of mental illnesses that cause constant fear and worry. So typically when you have anxiety, and I think a lot of us have anxiety, especially after COVID, that seemed to spike. But, there's a difference between like being worried about catching, like in general, how people were like COVID cautious, maybe you like wore a mask and you stood 6 feet away from people and you were a little bit worried about getting it. Like I'm gonna like wash my hands more often, but you still were able to leave your house. And, there is a group of clients or people that we see, and even people that function well in society that really worried all the time, excessively about COVID, and catching it and other people catching it. And it became more of a preoccupation with this constant fear. A lot of times anxiety, people have a hard time sleeping. They're very irritable, probably because they're tired. They have a hard time sleeping. They get really tense. Like if you ever notice, like your jaw, like I notice this with myself when I get stressed out, and I'm like, why have I been clenching my jaw? Like I have pain in my jaw, and I'm like, I've been all clenched. And then I notice that the rest of my muscles, like my shoulders are up, and I've been tensing up my muscles, but I don't. And then I go, oh, okay, well, I am worried about something right now. So it causes some of those physical symptoms too. People can just worry about something for no reason. They can worry after a traumatic event. You can get anxiety. There's kids that have a lot of anxiety about school, and especially if their school performance isn't great. Just anxiety for a lot of different reasons. And it's hard. So with anxiety, what we do is we want to counteract those like somewhat irrational beliefs with like rational beliefs. So if somebody's worrying that like the worst in the world is going to happen, we want to counter with like what's more likely. I always talk about anxiety being like your brain is taking a snowball and making it into an avalanche. Like you might be rooted in a kernel of truth, but your brain overdoes it. Like, worries about, makes it, catastrophizes it, for lack of a better word. Okay. So that's anxiety disorders. Then we have a group of disorders that involve psychosis. So, schizophrenia is one that we hear most often, and I'm sure that you work with people with schizophrenia. But there's also delusional disorder. There's one of them that we see pretty often with 1915 folks, and it's called schizoaffective disorder. So I'll talk about all of that a little bit. So what is psychosis? So psychosis is when somebody perceives or interprets things differently from those around them. And it may involve hallucinations or delusions, but it doesn't always have to. So I don't know if you've ever noticed, but it's really easy, it's kind of easy to tell when someone is responding to internal stimuli, is what we call it. So if they hear voices or they see things, because you can watch it in their face. And like I've met with people where I'm talking to them and they're like looking over and like there's no one over here to the side of the room, and they keep like looking over. Or some people will like mutter to themselves under their breath and really sound like they're having a conversation with themselves. That's because they're responding to things that they're seeing or things that they're hearing in their own brain. um, Schizophrenia and our schizophrenia is very, very hereditary. It's our most uh, commonly genetic mental health disorders. And it's something like if one of your parents has schizophrenia, you have a 1 in 4 chance of having schizophrenia as well. We usually see it more often in families, like a parent, one of their kids, more of their kids. It's just super hereditary. And so schizophrenia starts usually in early adulthood. So something happens, and there's different theories on why, but something happens to an adolescent, usually around like when they first leave home. So I have seen it earlier. I've seen a 16-year-old kid who's pretty psychotic, which is unfortunate. But usually it's around like they graduate from high school, they move away, they go to college, and just that big life shift causes enough kind of stress to the brain, and they have their first psychotic break. Once you have that first psychotic break, you can't undo it. Um, you can manage the psychosis, but you can't put it back in the box. So schizophrenia has what we call both positive and negative symptoms. Not to say there's good and bad about it, but the positive symptoms are the things that happen, that are added. So they're delusions, auditory or visual hallucinations, some disorganized thoughts. But then the negative symptoms of it are like the flat affect, like people really they're not emotionally expressive. They may have like quite a blank look on their face a lot. They may not talk with much emotion in their voice. They tend to be very just do move a little slower. So, and part of this is the medications that we give, especially those old frontline antipsychotics like Haldol, and those are can be very sedating. So that you can also see too. People typically have a hard time like completing tasks, remembering to shower. Some of those executive functioning skills are things that we help them with too. And then it's just very kind of limiting or preoccupying to have these constant hallucinations or delusions. The hallucinations are a little bit, I think, to live with. You really, the person, there's not enough medication that we can give. We can give medication to stabilize somebody, but a lot of people, even on Relprev or Abilify or Haldol, still has the hallucinations. They just aren't as troubled by them, but they're still there. Also, like the delusional thinking can be like what you see people when they're like preoccupied with, the government is spying on me, or aliens, or religion. It's the typical two most common themes of psychosis or delusions are the government spying on me or something to do with religion. Like it's very, very common. And I say to staff, like, it used to be like, oh, we could say the government's not spying on you. Well, now how do you know? Like it very well could. I mean, we all have a phone here that people can listen in on. So it's a little bit more, it's gotten to the point now where for people with schizophrenia, like that delusion is an entirely unfounded, which makes it a little bit harder to kind of tackle. Any questions about schizophrenia, psychosis so far?
What is the
Okay.
best way to kind of respond and communicate with individuals that are maybe hearing voices or seeing things off to the side?
Yeah. So a couple different ways. You can make sure that they're still hearing you. So, like it's a fine line we walk, because when somebody's really delusional and they're talking about, like, oh, what was this one woman recently talking about? She's asking me if I knew what bilocation was, and it's a religious thing where you're in like two places at one time. And I said, no, I don't really know what that is. And so she explained it, but that was it. Like, I didn't really get into it with her, like, and ask a bunch of questions about it, because that, if you do that, it kind of like furthers them down the path into that delusion, and you can't pull, it's hard to pull somebody back to like grounded reality. When you're talking with a person and they're looking at something, or you can tell they're talking to themselves, you can just address it with them by, saying like, okay, well, it looks like you're responding to somebody else. And then sometimes that like shakes them out of it, or sometimes they say yes, and you say, okay, let me know if you hear me, and you might have to repeat yourself a couple times. If they read well, you might have to like write down what you said so they can look at it later. But it's a lot of like repeating that information if they're really, really overly preoccupied. Okay. Bipolar disorder. So you hear people talk about manic depression. That's what bipolar disorder used to be called. It was called manic depression. And now we updated the language, so we call it bipolar disorder. So bipolar disorder gets thrown around a lot by just people in the general public, like, oh, I'm so bipolar, you hear people say that. It's not just like your mood swings from, hey, I'm having a good day, and then I get in a car accident and now I'm really upset, right? Or angry or whatever. Oh, I'm so bipolar. My moods change all the time. No, that's normal. Like, people's moods change depending on your circumstances, or have you eaten enough? Like, are you thirsty? That kind of thing. But bipolar disorder is a neurobiological disorder. Okay, so much like schizophrenia and ADHD, it's a neurobiological disorder. It's, again, very hereditary. We see it a lot in families. And it's it's mood swings that go from periods of depression. So you have to have periods of depression for longer than like 2 weeks that they're depressed, and then they swing up to mania. So a manic episode, a hypomanic episode, is these symptoms for up to 4 days. Full-blown manic episode is symptoms for 4 days to longer than a week, of basically not sleeping. So you don't need to sleep. It's not that you can't sleep, but you're just not tired. You um, you might speak really fast. Okay, so you people notice that your speech is rapid. You get this flight of ideas, grandiose ideas. You start new things. You start a new hobby. You're gonna, buy a boat. You make impulsive purchases. You might have promiscuous sex. All of those are manic, can be manic symptoms. And so the mania really needs to be medically, it's hard for people's brains to like come out of a manic episode without assistance. So you typically, at the end of a manic episode, or when we notice it, we'll hospitalize somebody for some medication management to help them bring them down, or people self-medicate with drugs and alcohol. It's really important to take mood stabilizers when you have a when you're bipolar, because that manic episode is almost like your brain having like an electrical storm. And so the more often that happens to your brain, the harder it is on it. It's also really hard on your body to be like swinging from like periods of extreme depression. All of a sudden you're not sleeping for a week. That's really hard on you physically. So what the mood stabilizers do is they smooth out that bell curve where, you know, it's either you're either down or you're up, or you're down or you're up, and they get somebody feeling like what we call, you know, normative, right? So medication is really the most helpful thing with bipolar disorder, and then also a lot of education about it. There is a seasonal nature, and I just know from working at the Human Service Center for like 14 years. The time change really affects people with bipolar disorder. There's something about like the extra sunlight can trigger a manic episode for a lot of people. And so we've dealt with that. We deal with it every like March. Like we just know, okay, get ready. We're going to see a lot more like crisis at that time. But so helping educate people in that, like I had a client who she knew when she was going to get manic, like part of it had to do with like the time change, but part of it had to do with like she could feel it coming on. And so she knew to like reach out to her med provider and like get an increase in her medication. For that time, she would like make sure she had like blackout curtains, and she would really like spend a lot of time in the dark. And that would help her because she really didn't want to be manic again. Like she wanted to stay pretty stable, because people, when they're in a manic episode, they do things that affect their life really negatively. Like they can impulsively quit their job. That's super common. And why would you need a job when you figured out the cure for cancer and you're going to make billions of dollars? So why do I need to work at McDonald's? Screw you, I'm out of here. And so it's hard to recover those relationships sometimes when you've broken them. Or like I said, like there's people who will like go and buy a new vehicle in the middle of a manic episode, because it's not like people are so, like twitchy, or you know, you can look relatively okay still. You're just talking really fast and really excitable. So then they like kind of come out of that and they're like, well, I can't afford this car I just bought. Well, the bank doesn't care. And so people put themselves in some pretty serious like financial ruin when they've got a lot of bipolar disorder mood swings. Okay. And then ADHD. So there's two different types of ADHD. One with hyperactivity, one without. They're both called ADHD. Go figure. But there's so attention deficit hyperactivity disorder is kind of categorized by like a lack of ability to focus, easily distractible, sometimes hyperactive and impulsive, can't refocus your attention. And it has a lot of like executive functioning skills, like can't prioritize or organize very well, has a hard time with time management. We see people with ADHD, and I know it qualifies you for 1915I services, but for the folks that you're going to see, it's probably not their only diagnosis. So again, it's neurobiological, so you have it throughout your life. You're born with it. It's just the way your brain is wired. It's a lack of dopamine kind of thing. But usually our clients have like also have an anxiety disorder, trauma, depression, or substance use disorder that we're working with as well. Okay. Major depressive disorder. So again, there's different types of depression. There can be what we call persistent depressive disorder. That's kind of mild depression, but it just doesn't go away. That's more like Eeyore and Winnie the Pooh. Like Eeyore from Winnie the Pooh is that just like persistent depression. Like he's not in bed, can't get out of bed depressed, suicidally depressed, but he's just never happy. Just, you know. Major depressive disorder is a 2-week period or more of most days you feel sad, you feel depressed, you lack motivation to do things, you might isolate, you might sleep too much or not enough. but your sleep's interrupted. You can have increased thoughts of death. You might be suicidal. And also, this isn't really in the well, it kind of is in the DSM. I think it's in the new one. But for men typically don't feel this like sadness depression, like they aren't crying all the time. And people with depression don't just lay in bed and cry. I mean, they can function fairly well, but they're just not doing it well. But men tend to get angry when they're depressed. Like they tend to, so you see more like explosive outbursts or violence from men than you would from women. But that's a kind of like we should talk to you about your depression if you're having these random kind of outbursts and you have all these other symptoms. Post-traumatic stress. Anyone have any questions about depression? Or anything else? PTSD, post-traumatic stress disorder. So PTSD happens, and it doesn't happen to everyone who's had a trauma. It happens in people where your brain tries to, like our brain kind of like, for lack of a better word, like keeps all our memories in like in like videotapes. Like you can pull out a memory and like bring it up and remember it, right? But we typically don't remember all of the aspects of the memory. Like, someone says, well, remember when we were kids and, so and so lived next door to us. Like I could maybe remember their name, but I probably don't remember their face. Like I just kind of lost that. You don't remember things crystally clear just because your brain doesn't have that much ability to, nor do you need to. But when you have PTSD, your brain takes an event that's traumatic and it holds on to that exactly how it happened. So then every time you think of it or something triggers you, reminds you of that event, it's like being right back in it. People with PTSD will have like flashbacks. Like you hear a lot about this from vets who have been in war, and they talk about, like, one guy told me he was sitting in his car outside of a gas station, and somebody's tailpipe like backfired and it made a loud bang, and immediately he was like, he had a flashback to like when he was in a firefight in Afghanistan. And it had to, he just, he didn't even know where he was. Like it took him a while to like come back out of it. And he was like, oh, I was just sitting here in the gas station, like didn't know how long he was there. People can have nightmares. That's super common with PTSD, is to have reoccurring nightmares about the trauma. And then they typically avoid things that remind them of the trauma. So I've heard of people who have been like sexually molested by, a family member, and they will, like, every time they smell the cologne, the same cologne the person was wearing when they were abused, they will they'll have a flashback, or they'll get really anxious. So that avoidance is common. And then people with PTSD are just like always on high alert, and they're always just more anxious than other people, and it's hard to trust. But we used to say that you had to experience like an event where you felt like your life was in danger in order for it to be PTSD. But especially after 9/11, that was updated, because a lot of those first responders who were doing the cleanup of 9/11 had PTSD from that, because it was just so traumatizing to them, the whole situation and seeing the dead bodies and so forth. So now it has to be just a mental health condition that develops following a traumatic event that either you directly experience. So it can be, a car accident, it could be war, it could be abuse that you've suffered, even like emotional abuse, psychological abuse. Children can get PTSD from like watching their parent being abused, like they watch domestic violence. And then it could be one trauma, or it could be a series of traumas or repeated traumas. And, you know, we talk to about trauma in terms of like adverse childhood experiences, or ACEs. And so that means the more kind of adverse childhood experiences that a person has, the higher likelihood for them to, well, first of all, they have much higher likelihood of developing an alcohol or drug use disorder. But they also have a higher likelihood of being traumatized again in the future. Just because, like, I don't know. I mean, there's a lot of different reasons for that. Partly it's the vulnerability that comes with being having PTSD, that makes you more likely that other people are going to prey on you or take advantage of you. But it's also that you're putting yourself in some situations that might be pretty risky. So I always talk about, because our clients, almost all of them have some sort of trauma, because either they had these childhood experiences, these ACEs that were traumatic, and then they turn to drugs and alcohol to cope, and then they further get traumatized in their drug use. Clients talk a lot about, well, selling their bodies for drug money, or watching fights, or being in physical fights, and just kind of like the the negative stuff that really goes along with a lot of that illegal drug use can cause some PTSD. Borderline personality disorder is on here. So personality disorders are maladaptive ways of coping that are brought on by a variety of different reasons, but usually their roots start in like some childhood, but we don't diagnose them till we're adults, because we know that that adolescents can, like, their whole goal of adolescence is like finding where you fit in and kind of changing your what am I trying to say? Not anyway, I'm sorry, I'm losing my train of thought. But you kind of like change your identity. Okay, so we don't diagnose borderline personality disorder until you're over 18, but it's a maladaptive way of coping and viewing yourself, other people, and the world. That's lifelong. Once you have that maladaptive coping pattern, like if you know about it, like people with borderline personality disorder, we talk with them in DBT about the symptoms and of their diagnosis, and they know about it, but it's kind of on them to change the way that they respond. So BPD is characterized by a lot of instability in mood. So a lot of that like emotional lability or mood swings. A lot of people who have borderline personality disorder get mistakenly diagnosed with bipolar disorder, because they have these like intense mood swings, but these mood swings will be much more short term, and they'll be like, I'm having a really good day, my boyfriend breaks up with me, and now I'm going to kill myself, or I'm going to slash his car tires with a knife. Just very quickly, their mood is shifting. And then a lot of instability in their behavior. There's a lot of like taking on of different identities based on like who they're around. This lack of trust of anyone. So they're either like, you're the best, like if you're working with you, oh, you're the greatest therapist I've ever had, and I've had lots of therapists, and you're by far the best. And then as soon as you say something that they don't like, then you're terrible, and they quit coming to therapy, and they never want to see you again. So it's very like what we call like very rigid in this like black or white thinking, and not really a lot of like understanding of like the gray areas. Also, there's a lot of suicidality and parasuicidality. So people with BPD they don't know how to ask for help in a appropriate way. So they do it by like through making a suicidal gesture. But oftentimes their suicidal gestures, like they will actually commit suicide, or they can be very, very intense suicidal gestures that need to be taken like really seriously. And then the other thing is just like this always a mistrust of relationships. So like, I'm going to do something, I'm going to leave you before you leave me, because if I get left, it's like I can't cope with that. And then a panic attack is a sudden episode of intense anxiety. People oftentimes feel like they're having a heart attack. It's an activation of your fight or flight response. So you're just very, very like activated, shortness of breath, sweaty hands, upset stomach, can't breathe, heart racing heart, and it lasts for anywhere up to like half an hour to a couple hours. Which is unfortunate. It's really, panic attacks are no fun. Any questions on any of those? Okay. So these are a couple of disorders that we see in children. Also, autism is again a neurobiological disorder. So you have it, it's the way your brain's wired, and you have it throughout your life. You just have to manage it. So it's a neurodevelopmental disorder, causes a wide range of impairment in social communication and restricted and repetitive behaviors. So, I mean, this can be like we can have people who have what we call like severe autism, who like are nonverbal. Meaning they don't speak, or they speak only in like echolalia, so they can repeat things, but they don't have their own language. They have a lot of like stimulating, self-stimming behaviors, repetitive behaviors, and maybe some like physical challenges. Or you have on the other end of the spectrum, because it's a spectrum, some very successful people have autism. So they're maybe very, very intelligent, they're very analytical, and they just don't understand like social norms. Like it's a little bit more than that, but like their social relationships are very impacted, and they're very routine based. Like people say, and I don't diagnose people I don't know, but it's very commonly held believed that Bill Gates has autism. Super, super intelligent, but if you ever heard him talk, he's clearly not like comfortable with people and talking with people. That's not really his forte. So that's autism. Disruptive mood dysregulation disorder. So we used to think that bipolar disorder only kind of came on when you were an adult, because you don't see the same type of like month-long, several months long depressive episodes with like all of a sudden a switch to mania for like a month and then you're back down again, like we do in adults. That usually happens with adults, but with kids, the mood disorder is much more like rapid. So they're more like they're always irritable. So they're like kids who are like always just, their natural mood is just like irritable. They get annoyed really easily. They can get set off, like they're very touchy. It's like a kid, you're like, oh, don't say, watch what you say, because he'll go off. And then they have these severe temper outbursts that aren't developmentally appropriate. So like this would be like you're having, a 13-year-old that is like, when they get upset, they're like breaking their belongings, like throwing their stereo at the wall. It takes them like hours to calm down. Like that would be more of that disruptive mood dysregulation disorder, which typically then when the person is older, it looks like, and it becomes more of that bipolar disorder characteristic. Oppositional defiant disorder. This is kids who are just like argumentative. They deliberately annoy people. They don't like to follow the rules. Maybe pick on their peers. They pick on other kids. and they're just defiant. Like they're just, and ODD is one of our disorders that's a lot more like behavioral, that you notice a lot of the behaviors from, but not a lot of like neurological symptoms from that. And then adjustment disorder is, I don't know if you'll ever see this. You might see this on someone's diagnosis page, but it would never be their first diagnosis because I don't think it's qualifies for 1959. But that's just like we're talking about, like you're having a short-term condition, managing a stressful life change. So like, work-related stress, or you lost your job, loss of loved ones, relationship issues. It's causing you to come in and seek help for that. But then after that, after you kind of work through that, it goes away. Adjustment disorder may turn into a longer depression or anxiety, depending on what happens. But if we can treat it, it usually resolves itself. Okay, so now we know the diagnoses. How does this diagnosis affect someone's daily functioning? So, some common skills deficits, because we're all about skills, that may relate to mental health symptomatology. Verbal, so you can tell in like their voice, their structure, how they speak. I mean, people with anxiety tend to speak maybe in a really rushed way. Sometimes people with depression are just very like monotone. They have flat affect. Like I kind of said before, people with schizophrenia can either be like agitated, or they can be very like flat in their tone of voice and in their facial expressions. You can also pay attention to people's posture, their personal distance. I once was working with a vet of Army vet, and he knows every exit point in all of our offices. So like when he comes in a room, he just knows how can I get out of here. And so what you see from him is like he won't ever sit with his back to the door. So when we go into a group room, he's always kind of like finding the spot where he has the easiest exit and his back isn't to the door. You see a lot of that guardedness in people with trauma like that. Yeah, people with depression can feel like they're just kind of like their shoulders are slumped, their heads are kind of slumped. Like you can tell that they're, they like, and they talk about, their depression, they're just very worn down. You can, paralinguistic, like the volume and pace and pitch of people's voices can give you away. Social perception is that, the ability to process information and make appropriate decisions and responses. Like we see this a lot in people with schizophrenia, like they just don't have that. So their responses might not be appropriate. Like they're in a group of people and everyone's kind of like laughing and joking around, and they don't understand that. So they're just kind of sitting there and they don't get that. Assertiveness, conversational skills, and then expressions of empathy, affection, sadness, all of those things can be, you can pay attention to. And then this is a really nice slide for, I think, those of us who are doing 1915I, the continuum of skills and services. So it's a collection of activities that correlate with the functional impairments listed above in each section. And you guys know these functional impairments because they are ones that you work with. So relapse prevention, what can you do then? Well, you can, actually, no, let's start at the bottom. So engagement is the biggest part of our pyramid. And I think with our clients, that's a lot of what we do is engaging them into services. And, it's not necessarily because they don't want services, but it might be because like something is, it's hard for them to access or to reach out. So go to them. You stay calm. When somebody starts like ramping up, the best thing for you to do is, stay very calm, talk very softly, have, relaxed body language. calming facial expression, make sure calm tone of voice. Don't scowl at clients. Don't roll your eyes at them. People are very sensitive to that. Evaluate their basic needs. Express empathy. Reframe resistance. This is all kind of motivational interviewing stuff. Cultivate patience. Examine your possible countertransference reactions. So it's a psychodynamic philosophy or theory that like what the client puts out kind of can trigger or affect us. So like I'll use anxiety as an example. So when I'm talking with someone who's anxious, right? I'm doing therapy with them. We're talking about their anxiety. I can like feel their anxiety rise. Like I notice myself like becoming more worked up, and I'll notice like my shoulders going up and maybe my heart's beating faster because and it like the anxiety just like it almost feels like it comes off the person in like emotional waves. So that's the transference. The countertransference is like how I react to that. So what I usually do is I say, like I find myself taking big deep breaths, and I'll tell the person, it feels like you're anxious right now. And they're like, yeah, I'm talking about anxiety. I said, like, I can feel it. Like, I can feel your anxiety. And I share with them, like, I'm feeling like my heart's racing and, my stomach is all upset. And they're like, yeah, that's how I'm feeling too. And I'm like, okay, why don't we both take a big, deep, relaxing breath? And so we do some deep breathing and we calm kind of both of us down. There's ways, so that's like an appropriate thing to do for your countertransference. There's a lot of ways that clients like trigger, we have a transference reaction to them, but we aren't insightful about it. And then we kind of do things that are not therapeutic. So working with people with personality disorders is very difficult because you get a lot of countertransference from them. It's a maladaptive personality style. So like if you maybe are like if somebody with borderline personality disorder kind of triggers that for you, the kind of the natural inclination of some people is to like cut them off, or like maybe like if they ask you for a ride somewhere and you're like, ugh, they always ask for rides, and you say, no, I don't want to take you for a ride. Like those are, it might be appropriate, but it might be like you're feeling this transference and you're just not able to have insight about it and not react. Reserve judgment, that's very important. We're the only non-judgmental, mental health care is the only like non-judgmental place in some people's lives. Like we can judge on our own all we want, but when we're working, when we're professionals, we are at the very basic non-judgmental. Be creative, listen, validate emotions. Anyway, just saying like, I hear you. I hear that you're upset. I see that you're sad. Like that's so validating for people. And you might be the only person in their life that does validate them. I can send this out to you guys and you can read it because I've been talking for 45 minutes now. But good skills to use for all of our clients: relapse prevention, healthy lifestyle, time management, household management, social skills, distress tolerance, problem solving. All of those things are things that are useful to everyone. What questions do you guys have? Things to talk about, things I didn't cover. Any specific, like, how do you work with this type of client? Totally throw it at me. Everyone's doing good. Okay. Is 1959? I know. Is 1959 going really well for all of your agencies, or you got a lot of people on it?
We have quite a few. We're learning every day, but I would say it's going good.
Okay. Okay. And who is this?
Community options.
Oh, cool. Yeah, you guys like are 1959 providers all across the state, right?
Yep. Yep.
Yeah, that's cool. It seems to me that sometimes you'll be working with the client like just on your own, and sometimes you'll be like a transfer from like a human service center to more community based, or another private agency to more community based services. And I think, and I like 1959 services because I think that they're increasing someone's freedom in the community and their chances of them remaining at the lowest level of care possible. If they can get some of their basic kind of like, care coordination, supported housing needs met, we don't have people ending up in like higher levels of care, meaning like residential and hospital levels. So that's the kind of the purpose of it. Okay.
Well, thank you, Stacy, for coming on. This was
Yeah.
really awesome and really informative.
I will talk about mental health disorders anyone, anytime, anywhere. It's my jam as a psychologist. So if you think of something or a difficult client example comes up and you don't have access to a psychologist who answer questions for you, you just get a hold of me, and I'm more than willing to like case consult with you. Well, thanks everybody.
Thanks, you guys. Thanks for coming, Dr. Hunt.
Yeah, no problem. Okay, bye-bye.
Bye.